This is the first time I've ever given this talk, so if it seems rusty, forgive me. I'm kidding, of course. I love this topic. Um, Intratumoral immunotherapy hasn't really existed. We've had some use of some oncolytic tumor viruses, but they've given, frankly, disappointing results overall. The first meeting that I'm aware of that's ever been held on this topic was 2 months ago by the Society of Immunotherapy in Cancer. It was a one-day virtual symposium, and the bottom line was more work is needed. At the present time, this is not ready for prime time. My hope is that after the presentation that I'm about to make, you will think otherwise. So you've seen my disclosures before. Prostate cancer immunotherapy, the first prostate cancer vaccine, the first immunotherapy ever approved was prostate. And of course, it was Provenge. And we'll talk about that. This is the only immunotherapy approved for prostate cancer. It does not have a significant increase in progression-free survival more than 4 months, and it's exceedingly expensive, and it has a side effect profile that is suboptimal, in my opinion. I was actually the pathologist on the phase 3 trial that got approval for this, and I've never been a particularly strong supporter of it, so please forgive my bias, but I wanted to share that with you. If we look now at the systemic immunotherapies that are used, there was great fanfare and excitement about this early on, and these are the data from about 10 years ago, and you can see that the anti-CTLA-4 ipilimumab had little or no effect on metastatic prostate cancer after radiation therapy, and 1% of the patients died. And the death is usually due to a hypersensitivity reaction, and they die overnight after the first treatment. It's a disaster. It also happens with PD-1 inhibitors, not just with prostate, but with everything. So these are not trivial agents, even though they're talked about and they're advertised on television. They have a death rate associated with them that is oftentimes unpredictable. A randomized double-blind trial at the bottom, as you can see, another anti-CTLA-4 versus placebo in a different group of patients. Again, no difference in overall survival. So the excitement about this in prostate went away pretty quickly. It works beautifully in melanoma, about 6% cure rate in patients who have failed everything else in metastatic melanoma. It's now approved, at least the one of the agents, and I have nothing to do with Merck, but Keytruda is approved now in 23 different cancers because it does have a significant, small but significant impact on survival. So this is one of the oncolytic viruses. This is Prostvac. This came out to huge fanfare because the phase 2 trial had very good outcomes. The animal studies were very exciting. And then they did the phase 3 trial, and this was arguably the biggest failure in the prostate field in the last 10 years. They performed this in over 200 sites and 1,300 patients, and they used these vectors with 3 co-stimulatory molecules for the T cell. Theoretically, this was a great idea, but realistically, it was worse, and it was stopped due to futility. And this caused some financial hardships for the company involved. I won't go into that. I had nothing to do with it. So a couple of quotes that I find interesting looking at this field. The first is prostate cancer is an immunologic conundrum. I love it when the People Memorial start talking like this. The checkpoint inhibitors, PD-1, have little or no activity. There's no role for this in prostate cancer. They actually said that prostate cancer is immunodead or immunocold, whichever you prefer. Then in 2017, Lanceti said negative late phase trials for an anti-CTLA-4 monotherapy and discouraging early phase for the PD-1 blockade as well. Negative, negative, that's what you're hearing. And the third one's negative as well. Another one combining these two, which has an even worse side effect profile than the 1% death rate that I mentioned, found overall no clinical activity. Primary endpoint was not met. There was a subset in those patients with DNA repair genes. It's about 4% of patients, and we'll see that next on this next slide. So trying to squeeze data out of things that are not working. They found super responders with anti-PD-1 live for 2 years. It's about 1 in 20 men, about 5%. And that actually was the first encouraging data for the checkpoint inhibitors. But survival for all men was basically no different than placebo. Um, I'm sorry, the mean survival I showed there is for the men who are the super responders. I'm sorry, I misspoke. So another one combining PD-1 and CTLA-4 inhibitors also found 4%. That was in a study that was presented just last month in Europe, and they found it slowed progression with patients with this very rare gene mutation by a considerable amount, and that's probably the most favorable data that we've ever seen, except for this data. Okay, I'm going to stop for a moment, and I want to go back in history 50 years. In the 1960s, there was no cure for acute lymphocytic leukemia. And someone decided, I think it was in Boston, this is in Emperor of All Maladies, you can read about it. They tried one oncologic drug and got a potential signal, very weak signal. And then they said, why don't we try two? This is the beginning of multiple drugs being used at the same time. And suddenly it popped up to 33% cure rate. Not response, but cure. 1 in 3 children under the age of 5 are now living, and some of them are still alive today who are treated. Then they went to 3, and the numbers went above 60%. We now treat acute leukemia in children in the subset of leukemias with some of the same drugs that were used in the 1960s, and the success rate is greater than 95%. I'm telling you the story because, to my knowledge, this is the first time that we decided to exploit multiple mechanisms of cancer control. We block here and here and here and here with different drugs. So in 2014, our group said, why don't we do the same thing with immunology? PD-1 inhibitors were approved that year, so we now have arguably the single most important immunotherapeutic available, the PD-1 inhibitor. And combine that with CTLA-4. PD-1 blocks, I'm going to simplify this, so forgive me for making it easy, but essentially the cancer is invisible because of the PD-1. But if you block the PD-1 receptor, the immune system can see the cancer cells. That's what happened. But it doesn't work long term because the cancer cells eventually adapt. Another mechanism, the CTLA-4 that I've mentioned, the mechanism is very simple. There is a feedback loop for the T cells. They're of course, the killer T cells, the cytotoxic T cells, which are they're the most important of all of the T cells here. And then there are the helper T cells or suppressor T cells, the same name, different names of the same thing. The suppressor cells, within a week, 2 weeks at most, will stop any of the destruction, the cytotoxicity, so that you don't have this autoimmune thing going on forever. So the thought was CTLA-4 can block the feedback loop, and then the T cells, the killer T cells, can keep killing for another 2 weeks, 4 weeks, 6 weeks until the drug wears off. That's the idea of the CTLA-4. So you got CTLA-4 stopping the feedback loop and the PD-1 making the cancers visible. That's not enough. It doesn't work, and it's got a terrible side effect if done systemically. Third mechanism, we need to unmask the cancer antigens. Those antigens are in the membranes, sometimes on the internal side of the membrane, on the outside, and the cell membrane is a very fluid environment. So it's like whack-a-mole. They come out, poke out, and then they go back in. It's constant. PSMA is one of them, of course. But that's what they're constantly doing. We have to somehow release these so that the cancer can be attacked by the immune system. The antigens, which are foreign, have to be identified. And we unmask them with a PD-1. We now have to make them available to the immune system because they keep disappearing. They come back and forth. And your cancer is different than mine. So if we pick one antigen, like they did with Provenge, it's not going to work terribly well because then the cancer will adapt. You need to go after all the antigens and use multiple mechanisms. So what we thought was, why not use 4 different mechanisms all at the same time? First, we have to expose the cancer antigens. How are you going to do that? Should we use radiation therapy? Well, that's slow, and it's not easily controlled necessarily. You can't use hyperthermia because that will coagulate the proteins and turn them all into the center of when you cook the egg, it all turns coalescent, and you lose the three-dimensional structure. You want to leave them intact so that if the long-lived cells that are floating around the body will see the antigens elsewhere in lymph nodes, metastatic sites, it will look the same. It can't be altered. So the best way to do this with an ablation technique is with cryosurgery. There actually are other ways of doing this. I'm simplifying again for simplicity's sake. So we used focal cryoablation. So PD-1 inhibitor to unmask the cancer. You got to expose the cancer antigens, all of them, being agnostic about which ones. You put a CTLA-4 in, and then you want to rev up the immune system, so you use a GM-CSF, not systemically. You put this in right straight into the cancer. That was the idea. So let me tell you about the first patient we treated. This was in May of 2015. 72-year-old, he had had cancer for 10 years, had been treated with surgery that failed after 8 years, radiation therapy that failed a few years later, went on Lupron and bicalutamide. Now he's treated with abiraterone, even had chemotherapy. Everything failed. So he's failed surgery, radiation, chemotherapy. He's now put on hospice care by the urologist and the oncologist. So he comes to see us with bladder and rectal invasion nodal metastases. His ureters were blocked. The prostate was gone, but in the prostate's place, in the fossa, there is a large mass that is blocking both ureters, requiring nephrostomy tubes to be placed. So this man's got, 6 months to live. We treated him one time. The treatment took 45 minutes, outpatient procedure, no side effects. He went home. We're shooting all of this we do cryosurgery, and I can't talk about the way it's done, but it's basically localized cryosurgery. And then we inject the drugs immediately thereafter, the 2 checkpoint inhibitors, and then the GM-CSF is given daily because it only has a half-life of about half an hour. It's given daily for 30 days to keep the system going, because the half-life of the checkpoint inhibitors is somewhere around 26 to 30 days. That's the idea. And we got a complete response of the metastases. We treated the prostate. We did not treat these lymph nodes. We didn't go anywhere near the lymph nodes, and they went away. I've never seen anything like this in my career. So I had 3 questions at that time. Number 1, can we do it again? Is it durable? And perhaps could it work in something else besides prostate cancer? Well, his PSA remained at about undetectable, but the mass in the prostatic fossa stayed there. It was still there. It shrank. It shrank so much that we could reverse the nephrostomy tubes, but it's still there today. So we finally did a biopsy after a year. We didn't know what to do. PSA is normal. The tumor mass is still there. What do you do with this guy? So finally, after a year, we got frustrated. We put a needle in, and it's all inflammation. There was no cancer. So he is alive and cancer-free for 9 years and 6 months. It took 40 minutes to treat him, 45 minutes. It's unbelievable. I've never seen anything like this before in my career. So let me answer the 3 questions. Number 1, we now know it's durable, at least in one man. Secondly, does it work in everyone? No, it does not. But a lot. And then thirdly, is it generalizable? Let's look at the data. This is in a series. This is a retrospective study of 17 patients. This is after first patient was treated. You can see that 35% of them were castrate resistant. We had a complete response in 35%. One of them did relapse. It turned out that it was not a Gleason 4+5 like the original tumor. Again, these are all metastatic cancers. It was a 3+3 on the other side of the prostate. For some of these patients, we didn't take the prostate out. We treated it in the prostate, and some of them we treated in the lymph nodes, as the case may be. We saw radiographic responses, 41%. Biochemical response. You can see the numbers. Survival has been remarkably positive. And the adverse events, interestingly, we're not getting any of the endocrine abnormalities you see with systemic immunotherapy. We have seen no hypopituitarism. We haven't seen any diabetes or destruction of the pancreas that we can tell. We haven't had any pneumonitis from any of the patients. So we had SIADH, of course, but other than that, we've had really nothing that was comparable to systemic immunotherapy. This is a different form of therapy, and it gave pretty good results. But these are observational results. They're not controlled clinical trial. It's a small number of patients, no long-term follow-up beyond the 9.6 years. It's off-label use of the drugs and devices, and it's only 2 providers that did this experience. So that's where we were about 2 years ago. Let me show you now the new data. It's never been seen before. Phase 2 trial, we published this as an abstract last year, and the paper is in final stages of preparation. 13 patients with metastatic cancer, all types, that came to us. This included, there were no pancreatic cancer, but we treated 1 bladder cancer patient who had a phenomenally good result. Cervical cancer, great result. A patient with head and neck cancer, and a handful of prostate cancer patients. I should have put that on the slide. We used radiographic response at 6 months using the iRECIST criteria, and we had a high disease control rate. That means stable or actual formal response, if you will, and a high abscopal effect rate of 31%. And that's what we were aiming for, is the abscopal effect. We treat in one place and we get a response elsewhere in the prostate or in the body. And we were seeing that in about 31%. Our adverse event rate greater than G2 was 16. Basically, it was 1 patient had that. So it looked like it was a promising thing, this multiplex immunotherapy. There's another study that came out 2 months ago. 15 men with metastatic castrate-resistant prostate cancer. They got 12 cycles. The most cycles you've seen in the 2 previous reports were 3 cycles. So now we're treating with more than 3 cycles. We meaning this group. I'm not involved with this group. Radiographic responses were also used, the iRECIST criteria, and they had a complete response rate in 38%. The durability of this has not been published, so we don't know. This is an abstract. So we'll see when the results come out, probably next year or the year after. But it seems to appear very favorable in this particular set. Anecdotally, we've treated another 150 patients, including 4 with pancreatic cancer, 2 of which had a complete response, at least in the short term. And we've treated sarcomas. They've done very well also with this overall. So it appears to be something that is promising. It is a new avenue of possible investigation. And it was shocking to me at this meeting that was held a month ago. We did not present at it. It was shocking to me that no one had come up with this idea that we had now 10 years ago. I'm kind of glad they haven't. So I wanted to share this with you. I am excited about it, as you probably can tell, only because it offers a new avenue, a new way to investigate things that are potentially immunodead, like prostate cancer, or immunocompromised in some ways. So this may be useful in the future for patients with prostate cancer and other cancers. Thank you.